Our first lecture is Introduction to Advanced Pathophysiology. First, I'd like to discuss the definitions of health and diseases. Pathophysiology is the study of disease processes and how it affects the body function. Pathos, meaning suffering, and physio, function of organs. Logos is the system of formal study, pathophysiology. There really hasn't been a more exciting time to study pathophysiology. There have been important advances in many areas contribute to our understanding of the disease process, such as genetics, immunology, molecular biology, and knowing more about the processes advances our ability to diagnose and treat. Disease process. So a disease is the interruption, cessation, or disorder of cells, tissues, organs, or body systems. Etiology means the cause. Pathogenesis is the sequence of cellular and tissue changes that leads to the disease signs and symptoms. Clinical manifestations, how they present, what they look like. Diagnosis, what you label it as. And clinical course, what that disease will look like as it progresses. So etiology or cause, it could be due to a physical force like trauma, it could be biologic like an infection, can involve inflammatory and immune responses, a chemical cause, a genetic cause, nutritional excess or deficits. Most diseases have multifactorial causes of origin. So we do categorize etiology in a few different ways. First one is idiopathic, where it's unidentifiable. Acquired is one that develops after birth, and congenital is present at birth. Genetic is something that you inherit. Nosocomial results from being in a hospital. And iatrogenic means the result of medical treatment, either from the drug treatment or physician themselves. Clinical manifestations. These are our signs and symptoms that we see. So signs are objective findings. So things that we can see like a fever, a rash, swelling. Symptoms are subjective findings, what our patient tells us. Some examples are fatigue or pain. Now, a syndrome is a cluster or a compilation of a bunch of different signs and symptoms that reflect a disease state. Complications are the extensions of a disease or adverse outcomes of that disease. So diagnosis is that identification of the disease or syndrome. It may be a long process. It may begin as what we call a working diagnosis. It depends on getting good interview skills, good physical assessment skills, and then reliable and valid diagnostic studies and tests. Might require calibrated blood pressure cuff, lab equipment, and proper technique. A couple terms that I want to go over are sensitivity and specificity. Now, every lab test, x-ray, physical findings, things like that can be examined for sensitivity and specificity, and that is given as a percentage. Both sensitivity and specificity should be high in order to get a good predictive value. It tells us how much we should put trust into that test, if we can believe the results or not. Sensitivity identifies the portion of people who have the disease and are positive on a test for that disease. It's given as a percentage. The higher the percent, the better the test is at picking out those with the condition, a true positive result. But it could also show false positives. So to simplify it, If a condition is present, how likely is it that that person will test positive? That's the sensitivity. Now, specificity is the percentage of people without the disease who test negative on the test, a true negative result. This is the ability, specificity is the ability to identify persons who are truly well, that do not have the disease. So, sensitivity and specificity need to be considered with diagnostic tests. False positives can lead to stress for the patient, inappropriate treatment, and then false negatives can misdiagnose patients. So let's put this sensitivity and specificity ideas to actual practice. So if we were to do a diagnostic test to see if a patient has a disease, we're going to want to look at what we call true positives, false negatives, and true negatives. So you can see over here, we have our test. And we can get either a positive result or a negative result. All right. So if our test comes back positive and it's accurate, they actually have the disease, it's present, we call that a true positive. Now, let's say their test came back as positive, but it was wrong. They didn't actually have the disease. That's called a false positive. Now, if their test comes back negative, but it was wrong, and the patient actually had the disease, that's a false negative. Now, if it came back negative and they actually were negative, then that is a true negative. And the sensitivity of a test. So that identifies the portion of people who have the disease and are positive on the test for the disease. So an example of something that's 100% sensitive means it picks up everybody that has the disease. It might pick up people that don't have the disease as well, though. So you can see we have our net. This is the test, and these people in blue are the people with the disease, and these people in white do not have the disease. So the test is 100% sensitive. So this net is going to catch everybody in the blue, but it could also catch some people in the white. So we may have some false positives with this sensitivity. So sensitivity is very important, but so is specificity. So these down here are our negative test results, those patients that do not have the disease. So specificity comes in where we have the percentage of people without the disease who test negative, so true negative. So an example of specificity of 100% is this net is going to catch everybody who's well that doesn't have the disease. So this net is going to come by and catch everybody that has these white circles, but it may catch a few people with the disease as well. So you can see here that there's going to be some false negatives, people that do have the disease, but they tested as negative on the test. So you want a combination of good sensitivity and good specificity in order for a test to be a really good test. So let's talk about one of the tests that could be out there for disease testing. So prostate specific antigen, or a PSA. This is a test that has a 21% sensitivity for detecting any prostate cancer, any level of cancer. And it's a 51%, so a little over half of high-grade cancers. Those who have prostate cancer will show an elevated PSA, so it'll be high. Now, so the sensitivity isn't great because it doesn't catch everyone that has prostate cancer. So some people may have a low PSA, but still have prostate cancer. Specificity, though, is pretty good. It's 91%. So those that do have a high PSA actually do have cancer. So it doesn't catch everyone, but the ones that it catches, it's pretty good at saying that they do have cancer. Now we're going to talk about a few more terms. Predictive value. So there's the ability of a test to predict the presence of a condition or a disease. We say condition because it could be pregnancy, and that's not a disease, in a population. How good is it at that is the test at predicting? And then there's the positive predictive value, so the proportion of true positives in a population. So for that PSA, the positive predictive value was somewhere around 30%. Not great. But the negative predictive value is the portion of the true negative results in the population. So the people who come back negative truly do not have the disease. That's the negative predictive value. So the negative predictive value of a PSA is 85%, which is better. Some more terms. We have clinical disease states. So the term acute conditions. Patients show signs and symptoms, sometimes severe, often self-limiting or resolve with treatment. So it is something that happens and then most of the time kind of goes away. So you don't, when you get a cold, it's not a chronic condition, it's a short term. You have the symptoms and then it goes away, hopefully. And then there's the chronic conditions. Those are the continuous long-term processes. These are not curable conditions. They could be controlled and managed, but you might have periods where there's exacerbations where it gets worse and remissions when things get better. And then terminal diseases are when it eventually will lead to death. So epidemiology is the study of disease occurrence in a population. It identifies patients' risk factors, how that disease is spread, how to control it, and how to prevent it. There are a couple terms that are important for epidemiology. One is incidence. This is the number of diagnoses within a time period. For example, the incidences of COVID-19 between April and May. That would be the number of new cases divided by the number at risk. So new cases per 100 people. Now, prevalence measures the number of existing cases divided by the population. So with heart failure, as an example, you may have new diagnosis of heart failure, which is incidence, but prevalence would be everybody that has heart failure now. So that could be people who were diagnosed years ago. So incidence and prevalence. Mortality is the number of people who die from a condition. It's the leading cause of death, often reported by age groups. So people who die at age 30, 40, 50, and so on. Now, morbidity is the effects of an illness on a person's life. So maybe they have to have dialysis or they get other complications. They have disability as a result. So mortality and morbidity are often used hand in hand, but mortality is related to the people who die, and morbidity are the people who have some kind of effect on their life. So let's take a look at the number of deaths that occur in the United States. So heart disease is about 600,000 deaths a year. Cancer, also close to 600,000. Stroke, 100,000. chronic lower respiratory diseases, so in their lungs, accidents, diabetes, Alzheimer's, influenza and pneumonia, renal failure, and septicemia, so infection in the blood. The term risk factors, these are conditions suspected to contribute to the development of a particular disease. So, a risk factor of lung disease would be smoking, all right? So if you're a smoker, that contributes to lung disease. It's also a risk factor for heart disease and things like cancer. So smoking is a risk factor. This is important in epidemiological studies and cohort longitudinal studies, such as the Framingham study that was started in 1950, and it looked at over 5,000 people and what led to disease development in these individuals. They monitored their lifestyle and the risk factors that led to the development of diseases. It's also been used in longitudinal studies with the Women's Health Initiative in 1991, and the Nurses' Health Study started in 1976. When it comes to the prevention of disease, we categorize it in three main types. There's primary, secondary, and tertiary. It's important to understand the different levels of these types of prevention. So primary are interventions which prevent the disease from occurring. So don't smoke, that's a preventative measure to prevent lung disease. Secondary interventions which detect the disease early. So screening tests for cervical cancer, screening tests for breast cancer, things like that. That's catching it early. And then tertiary interventions prevent further deterioration after you get the disease. You prevent complications, mortality and morbidity from occurring with these diseases. So when we treat a condition, we're going to use what we call evidence-based practice. This is going to be a common term that you hear throughout your nursing career. The conscientious, explicit, and judicious use of current evidence in making decisions about the care of individuals. This is the basis for our interventions. Nursing research and research from other disciplines impact our practice. Practice guidelines are systematically developed by multiple specialists who review research, literature, and clinical expertise. Recommendations are made to guide the management of conditions such as asthma, cholesterol, hypertension, and pressure ulcer prevention. We can find our guidelines by going to websites such as guidelines.gov, and we can find our practice guidelines for things like management of high blood pressure, treatment of high blood cholesterol, and then guidelines for diagnosis and management of things like asthma. The goals for nursing and pathophysiology are first, to recognize abnormal conditions, to understand the etiology or cause, understand the pathogenesis and course of the disease, utilize preventative interventions, understand and implement the collaborative management, and monitor the patient's response. Additional sources for information for pathophysiology are textbook student resources, clinical practice guidelines, databases such as UpToDate, internet sources for professionals, so the National Institute of Health, the American Heart Association, and then other video sources.